I think that's a great answer, very sophisticated. I can imagine, though, if you're a primary care physician on the front lines, you just said a lot of stuff. You said CRP, you said CAC, that's coronary artery calcium. It's a lot of different, LP little a, which perhaps not everyone measures, but the most recent European guidelines actually said everybody should have it measured once in their life. So what do you think, you're a chief of cardiology, you've got to provide some guidance to a healthcare system. How do you deal with that? What should the primary care physician be responsible for monitoring and measuring, and when would you refer along this continuum of risk? Not the easy stuff. If somebody's got, angina climbing up a flight of stairs, obviously that'll prompt a referral to the cardiologist. If someone has a heart attack, heart failure, not the easy stuff, but I mean more in this continuum of risk short of actual ischemic events.
Yeah, so as you said, it's not so straightforward, and part of why we've made messages that are sometimes complicated, right? We've said, oh, it's not the LDL, it is the LDL, it's the drug, right? So we've not made it easy for people to follow all the time.
Yeah, same with LP little a. I mean, now it's in, but at prior time,
right, why is it back? Or calcium scoring, don't do it, right? So I think one way to think about it is to, as you said, it's a continuum of risk. So just start with what's the best risks way of figuring out the patient's risk. And so what we tell people, much like the guidelines, is for those that, and it is sort of artificial to start with events, but those that haven't had events, we're going to ask you to calculate the ASCVD risk score or the atherosclerotic cardiovascular disease risk score that the guidelines, and now I think in practice are pretty well known, which try to project what your 10-year risk of having a cardiovascular heart disease event, stroke, heart attack, or death due to heart disease is. And in that group, what we tend to say is, if you get a high risk, right, you get a 7.5%, 10%, you get high, you're going to be treating. If you're low risk, let's say 5% or less, we're going to be doing a variety of lifestyle modifications and potentially getting you to a goal of, let's say, an LDL that's not as low as I've described before, where that 70 cut point is for that high risk. Where the tests you described, I think, are important, and often is where you might get a referral, because outside of ordering the LP little a, but if you wanted a calcium score, you wanted to act on that, you're trying to convince a patient to take a statin or do something else in their life, there, I think a lot of health systems beyond, and a referral may not be to a cardiologist, it may be to a dietitian, it may be to a pharmacist, right? It's a variety of places you're going to try to build that system. But between that intermediate risk, which I actually think is the majority of people, unfortunately, in the United States and growing, those that are at risk to have cardiovascular disease probably need to be treated, might need one more piece of data to make them think they need to be treated, whether it's a scan of their heart, a lipid level, or a subparticle that tells you, oh, I'm at high risk, an inflammatory marker.
Right. And so back to the point of what does a primary care come back to, I think our guidelines sometimes do us a disservice when it comes to LDL cutoffs.
Yeah.
And so what I mean by this is that NLA, ACC, AHA may all have different cutoff points, and then sometimes we have to, right, and they do, and then we have to utilize
throwing the endocrinology guidelines. There's different sets there.
Absolutely. So then now, as a primary care physician, you're seeing, let's say, someone that has diabetes, is 60, has CKD stage 3 and hypertension, and they're coming in just for an annual follow-up. You have 5-10 minutes to make this evaluation. How are you really gauging it? But as I tell my PCPs, that's actually the patient that we want to treat now. If we treat that patient, and in my opinion, based on histopathology and whatnot, if you have an LDL of less than 60, you are it's going to be very difficult to form new plaque. And so I'm quite aggressive with lipid management, albeit statins or non-statins, and I'm really big in the diet world. And so my point is that we need to do something, and it could be up for debate on how we treat it. Not everyone needs to be treated with statins, but I think that is going to be where we're going to target primary prevention better. Would you guys agree with that?
You said something interesting about LDL. What do you think, John, if the LDL is really well controlled, and one could argue about 60 as a number, but let's say the LDL is 30, and it's been that way for a little while naturally or with pharmacotherapy, person's stable. What is the incremental value there of antithrombotic therapy? If that LDL has been in that 20 to 30 range for the past 3 to 4 years, maybe even the person did have an ischemic event in the past, but now LDL is controlled, non-smoker, is there still value of stacking antithrombotic therapies?
Well, it's a really good question. I don't know that we have a definitive answer for it. What we do know is that they're on that continuum of risk, and if you get your LDL super low, you're going to drive them down in terms of risk. The lower you are on the risk continuum, the smaller the absolute benefits of stacking risk modifying agents. So I don't know. I don't know if I've seen anybody with an LDL of 30, but I guess as a hematologist, I'm just happy they're on something. I'm probably more a primary care provider than you, because you're all dealing with advanced vascular disease. But we've learned from, and we'll talk later about some of the trials, but if you've got a really well-controlled risk factors, the incremental benefits, say, of antithrombotic therapy are going to be more modest.